Good morning, friends. At the outset, I would like to thank Mr. Kumar for giving me this opportunity to be part of this course. I'm going to talk to you on the surgical intervention in diabetic macular edema. I have no financial disclosures. We all know that diabetic macular edema is a management challenge, and this is the commonest condition we, all of us interested in retina, have to tackle day in and day out. Since the DME is a chronic disease and it requires long-term strategies, and we also know that this is something which is multifactorial, because basically this is because of a systemic disease. So management is also in a multimodal fashion. So we know that we go with the metabolic control. We have lasers. The role is going down probably at present. Of course, intravitreal anti-VEGFs and steroids, they are really on rise. And I'm just going to confine myself to the partial vitrectomy and its role in cases of DME cases. How this whole business of partial vitrectomy for DME came, I think there have been a lot of studies, if you go, that PVD may resolve DME spontaneously, and this has been seen. And the lower incidence of DME is always seen in PVD is seen in DME cases. We also find many of these cases having vitreoretinal adhesions and incomplete sort of a PVD in these cases. So release of the abnormal vitreomacular adhesion with elimination of maybe trapped VEGF may improve DME once we do partial vitrectomy. So once we talk of the indication for partial vitrectomy in DME, DME with taut hyaloid, I think this came way back. This is almost going back 20 years when some of the studies were done and it was found effective. And so is the DME with vitreomacular traction. And then are the epiretinal membranes. Probably we knew about them, as well as these epiretinal membranes could be both vascular and avascular, overlying the macular surface, which will produce the distortion of the macula. Then the last is recalcitrant DME without vitreomacular adhesions. So, and if we look at these indications in the present context, these are getting much more well defined, and early PPV at this time is indicated in the tractional type of diabetic macular edema. However, once we talk of a vitreomacular adhesion where you don't have an adhesion, then in some of these eyes, you see, the problem is, I think it is not happening only because of the traction there. There are other factors which are responsible. So sometimes we just think, no, I'll just remove it and everything will be all right, which is not the case probably in many of these cases. And of course, still the partial vitrectomy in case of recalcitrant DME without vitreomacular adhesion is still a controversial subject. I think we might have a case like this. This is a tractional DME. In fact, you can see traction better here in the 3D picture. Now, we are not really sure that this whole thing is happening because of the traction. This might be happening because of even other reasons. And then you have something like this. Maybe, I think here, major component is because of the vitreomacular traction. So that is understandable. So I think it is very important for us to talk to the patient in the beginning, because many a time there are unrealistic expectations, so not in a DME case. So the visual prognosis may be variable. Patient may stay where it is or may even worsen in about 10% of the cases. So we have to explain the risk-benefit ratio, including the risk of further loss of vision after surgery. And we must have informed consent. I think it's much more important in a case where probably you have a disease like DME. So all like 20, 23, 25G, they are possible, and we do partial vitrectomy and try to remove the posterior hyaloid and peeling of any associated ERM. ILM removal, it's not like macular hole, where it is essential, it is very well established. Here it is really controversial. So you may require gas tamponade very rarely in these situations, even if you have removed the ILM. This is way back, the case done in 2003. You can see there, and just in 6 days, everything goes down. And this is also the same, I think, done same year. There's a thick ERM here and partial vitrectomy, and these are all time domain pictures here. And of course, this is the case which I'm going to show you a small video clip. You can see this is a 67-year-old lady, 6 by 60 visual acuity, and you have this kind of a taut posterior hyaloid membrane there. And so here, what has been done is that the ILM is not peeled, only the external limiting membrane is being peeled here, only the ERM is being peeled here. So once you remove the ERM in such a situation, I usually don't prefer to remove ILM. So there are reasons for that, which I'll briefly touch upon. And so you remove this, and once you have removed this, I think if everything is fine, you can just leave it at that. You don't need any kind of a tamponade, or you need nothing in such a situation. So this is the case now down the line. You can see the date there, and so this patient in about almost approximately 3 months, she's 618, very happy from 660, and you can see now, you can even see the fovea. You can see everything doing very well here, and this is the OCT. You can see the contour has come back and the thickness has gone down. And this is another case. You can see again a large cystic area here. Probably a small gas bubble was put because I think there was a tiny little break. And this is another one, very thick one sometimes you have, and you can see marginal gain because everything is deposited right into the center. And this is what happens. I think this lady, practically one eye, relatively younger, I was reluctant to operate her all the time. And her vision was going down, and they pushed. And here there is a clear-cut macular hole. And the macular hole was, the ILM was peeled here, and we had to put a oil tamponade. You see, the problem is there is a neurosensory atrophy. That is what bothers me. And now she has just gained about a count finger vision. So that is what sometimes happens. She remained probably where she was. And so these are some of the issues where we don't understand. Of course, we do have these cases sometimes, younger patients, and they have these kind of vascular membranes distorting 660 vision. This case, we had to give injection because it was so vascular, and of course you remove, you get rewarding result. So these are some of the vascular ERMs which you would remove, and this was almost 6'9", very happy patient. And of course you should be very careful. I think this is one example. We feel there is a ERM, there is vascularization, you give injection, the whole thing may crunch up. That is what can happen at times, that's the problem. So as far as DME surgery is concerned, VMT on OCT is not uncommon, but it may not be the primary cause, as I said, in all cases. So both tractional and biochemical factors, they play a role, and this is being taught more and more at this time. So at this time, what is being thought of, that we must give a trial of pharmacological therapy before PPV, because many of them, they may respond, and if they don't respond, then only consider surgery. So this is what most of the time is being thought. I think the beneficial for both functional as far as the ILM is concerned, I think there's a publication from Dr. Atul also here, and we are not really sure at this time if the ILM peeling in non-tractional DME really improve the outcome. It does improve the anatomical outcome, but functionally it has been debatable, and most of the time it doesn't. And there has been a debate about also whether ILM peeling lead to papillofoveal distance is shortened, the retina gets more thinner, as I shown, and up to 20% ganglion cell loss has been reported by some people. So in conclusion, I would say that PPV has a beneficial role in tractional DME. I think we should start first probably a pharmacotherapy at this time. ILM peeling is controversial. At present, we are not able to predict which patient would benefit from surgery. And in future, probably we'll have more defined indication, I'm sure, as we are getting better imaging modalities, as well as the pharmacotherapy is also improving. Thank you.